when you leave out of general anesthesia, all right? Because general anesthesia puts everything to sleep. The lungs, the digestive system, everything. And so what they're doing, they come in and they'll be like, okay, let's test your breathing. They get you to breathe. They want to make sure that your lung capacities, basically these volumes that we know exist, are getting the lungs back into motion.
I know when I first saw this, I always thought that you would like blow into it, but it's actually you're sucking in, and it gives you, it does look like you're supposed to blow into it, but that's actually not what you're doing with it. They're actually trying to suck in as much as they can.
Because when we begin to look at volumes, we're going to have inspiratory volumes, we're going to have expiratory volumes. There are going to be all these volumes that are present. We need to make sure that the rate and depth are good, the speed is good, because the goal is to make sure that we are still delivering oxygen to the tissues of the body so that the cells in those tissues can use the oxygen. These are volumes that they can measure. Like I said, if you're going into respiratory therapy, this is something you're going to become very familiar with. They will take volumes that they can measure, put them into mathematical equations, and determine respiratory function. That means, is that function falling within normal conditions, or could there possibly be an underlying respiratory disorder present? So we're going to find we have something called tidal volume, inspiratory reserve, inspiration, expiratory, breathing out, and then residual, whatever's left behind. Tidal volume. What is the amount inhaled and exhaled? That's one breathing cycle. Once again, numbers are going to fall under a norm that has been created. Other factors will affect this. For example, volumes are different between a male and a female. Volumes are different based upon physical condition. So volumes will vary, but this would be norm values. An inspiratory reserve. Now, if this is the norm, basically what they tell us, when you breathe in, if you continue to force that air in, which is what they'll make you do, okay, you could inhale up to that much more, up to 6 times more air. Does that make sense? Because if this would be the norm, and if they're sitting there going, no, keep breathing in, okay, you keep breathing in, they're saying you should be able to get up to this, norm conditions. So, if we do our normal exhale, guess what? They're saying on the exhale, if they keep standing there going, keep breathing out, and you're pushing it out, that, I know, right? And that's what they want you to do. Any of y'all ever had to be around that? that this is how much you could breathe out on the norm. That's what would make that little, in this respirometer, there's actually like this little ping pong ball right here. And as they're telling you, because they'll be there and they'll say, breathe in, and they'll be watching, see how it's got the numbers on it? They'll be watching that ping pong ball and how high it goes. And that's what they're looking at. So they'll take all their little values, all their little numbers. Looking at this, residual would be what remains behind in the lungs. And they'll take all of their little numbers, ta-da, and get those capacities. Question?
Why is maximum in more than twice the amount of maximum out?
I'm not a respiratory therapist. What goes in is twice what goes in. What was the question again?
So the maximum inhalation is something like 3,500, but the maximum out is something like...
Because of what stays behind,
Yeah, you're not
the residual.
firing everything.
Yeah, you don't breathe everything out. So, they'll take their numbers. They will determine a capacity, vital capacity, inspiratory capacity, functional residual, and they'll end up with something called total lung capacity. As the respiratory therapist continues to monitor you, now it could just be a situation where maybe you had surgery, maybe you're in the hospital for another reason, but the respiratory therapist, if they're just monitoring you, they would come in several times per day. They would know how to look at these numbers and put them in and do the math, probably in their head, and determine, okay, well, maybe we need to get them some oxygen. Then they would know how much you should be getting. Because when they do that, they have a little measure thing, okay, on their equipment that knows how much to let it flow. They'll look at other stuff too. They'll look at like the pulse ox, that sort of thing, okay? It's really cool. It's really cool. It's just not one of my areas that is in my knowledge, all right? They do the spirometry, this testing, definitely in people who have known lung disorders. Restrictive disorders, it's one group for classifying a lung disorder. Another way to classify them is obstructive. Restrictive, restricting something, okay? Somehow, the pulmonary compliance, the ease with which that lung and thorax expand, something is restricting that. Therefore, the inflation of the lungs is restricted. Usually, they identify it because of what gets affected in the numbers on their capacities. Good examples of restrictive lung disorders: black lung disease. Anybody ever heard of that? This is the disorder that people get working in coal mines, okay? TB, tuberculosis, all right? Obstructive disorders, which kind of seems backwards to me, but this would mean that there's a blocking or that airway gets narrowed. For example, asthma, Anybody in here know somebody with asthma? Okay, you personally or somebody you know personally? And probably the first time that something happened, I don't know how old you might have been. Was it younger?
Younger, I think it was 5th grade.
Oh, so you were still old enough to remember then, probably that first episode. And you probably felt like the breath was not in there, that you were, you know, in a panic and that sort of thing. So from what I understand, asthma is a very, I think one of the things that happens, the people really struggle, okay, and it gets panicked, okay. But a lot of the medications that they've come out with now actually go to the level of this muscle, the smooth muscle, to relax and so forth. Chronic bronchitis, usually seen in smokers and so forth. What they look for, what is the forced expiration? Brian? Oh. What's the forced expiration? People who will have obstructive disorders, their volume that they can force out, okay, that 3,000 milliliters, is that right, or is that inspiratory? Out was 1,200, I think, okay? So their volume drops. Their volume would not be equal to what someone under the normal conditions would have. Your textbook has a table with different information, letting you see some of these volumes based on the different disorders that are present. So just take a peek at that. Now, here we go. Because we've got to get to the point where we're at that alveoli okay, the great, and our capillaries. And in between the two is the respiratory membrane. The respiratory membrane, just once again, water-based, all right? Because that's going to come into play with Henry's law. The air that's around us, we have nitrogen, we have oxygen, we have carbon dioxide, other minor gases that can be present. When we look at the gas laws with breathing, we have to think about how in the air that's around us, there's a pressure on the external side that will affect the pressure internally. You get on a plane, what do? They pressurize the cabin. Pressures are how we're going to exchange the gases. Like I've said, well, pretty much like we know about diffusion. Materials like to move down their concentration gradients, okay? They like to go from an area of high concentration to an area of low concentration, which is fine and good, okay? Because in our minds, we would be thinking oxygen should be high in my alveoli, correct? And that CO2 should be high in the capillary. Is everybody following me? And that once we get to the lungs, because this is what we've been taught,